moving into the final session of the afternoon. We're going to have Dr. Cohan talk about an update on COVID-19 vaccine administration. Dr. Cohan, please.
Great. Good afternoon, almost to everyone. And I promise my slides will be easier. I won't be spastic with my slides for this presentation. So my goal today is to give you a high-level update on where we are with vaccine administration. I'll start by saying I know that there are lots of questions and lots of challenges. I'll try to address these at a high level, and then we have some time for questions. Next slide. So as of January 25th, 2021, we have 11 states that report being in phase 1, 38 states that report being in phase 1B, and 2 states that report being in phase 1C. At the bottom of this slide is a link to the Kaiser Family Foundation report that updates this regularly. It also talks about variation between the different phases, including age group and differences in essential worker populations. And that's very helpful if you want to get a sense of all the different things that the states are doing. The ACIP prioritization recommendations are intended as a framework to support equitable and efficient administration of COVID-19 vaccine and jurisdictional flexibility. So as we discussed at multiple other ACIP members' meetings, it's not necessary to complete one phase before expanding into the next group. And we do want jurisdictions to start to move into other age groups as, for example, demand starts to decrease in persons aged greater than 75 years. We think it's really a critical part of this is to use all available doses and to minimize waste, even if that means giving doses to somebody who may not be in an eligible group at that moment. However, a key principle is that we need to continue to offer vaccine to persons in earlier phases, even if they refused vaccine the first time they were offered. Next slide. CDC is committed to transparency on our vaccine administration data. We are getting to somewhat of a more steady state, both with vaccine ramping up and with our reporting. And on February 1st, on Monday, we will be publishing 2 MMWRs showing early administration data, both in long-term care facilities and general demographic characteristics of the early groups that have been vaccinated. Vaccines have been shipped to over 18,000 providers. When you're looking at this data, it's important to understand that these vaccines require large minimal doses of 100 doses for Moderna and over 950 doses for Pfizer. So this results in high inventory when doses are received. For example, if a vaccination site receives 100 doses of Pfizer vaccine twice a week, or once a week, there will always be days when they are reporting a large amount of inventory. Social distancing rules, social distancing requirements does reduce throughput and requires both scheduling of vaccine appointments as well as an increased workforce to manage the need to watch patients in a socially distanced way for 15 minutes after vaccination, and other requirements of remaining socially distanced. And finally, it's important to understand that our doses administered per day increased, especially after the holidays, which means an increased number of doses, now we're 3 or 4 weeks later, are now being assigned to be administered as second doses. So this shows our overall COVID-19 vaccine distribution and initiation, and this data is in COVID Tracker, and in the very near future, we will be increasing the amount of data we're able to show in COVID Tracker. But for now, we have distributed over 44 million doses of vaccines. So doses distributed means that this number of doses have been received by the jurisdictions. The total doses administered is over 23 million doses. This includes nearly 20 million persons receiving 1 or more doses and nearly 3.5 million people who are fully vaccinated with 2 doses. On the slide, on the bar graph, you can see, as expected, we were administering Pfizer vaccine slightly earlier, but both products are being used broadly. Next slide. This slide shows the total number of doses administered by date of administration, and you can see Pfizer vaccine administered in blue and Moderna vaccine administered in orange. The line is the cumulative doses administered. It's important to note the shaded part reflects the several days it takes for vaccines to be reported. So it's doses are administered and then have to be entered through a reporting system. So you'll see that we will still be filling in that shaded part of the graph likely over the next several days. What's important to note here is that since mid-January, actually early January, we've been seeing nearly over 1 million doses of vaccine administered most days of the week. What you can also see here is that while our Saturday number of doses administered declines, our Sunday doses administered is extremely and continues to be low. But in the last week after Martin Luther King Day on January 18th, we've seen several days where we've had over 1.2 million doses administered per day. Next slide. This data focuses on the Federal Pharmacy Partnership for Long-Term Care, for the Long-Term Care Vaccination Program. And the bar graph, so overall, we've had over 2.7 million doses administered in long-term care facilities. Over 2.4 million people have received one dose, and we're just at about 250,000 who have received both doses. The bar graph demonstrates that residents of long-term care facilities, over 1.2 million, have been vaccinated. Over 800 staff have been vaccinated, but these long-term care facility clinics and long-term care facilities are reporting low vaccine uptake and vaccine hesitancy in long-term care staff, especially in some states. Early information is showing that these clinics, when they go back, each vaccination clinic will go to the long-term care facility 3 times. And when they're going back for those second and third times, there are staff that are accepting vaccine on those second and third visits. So continuing to capture those staff that did not accept vaccine early will be really important as we try to eliminate outbreaks and protect both staff and residents in long-term care facilities. Next slide. So I know that there's a lot of questions about why we are seeing more doses distributed compared to the number of doses administered. And I've tried to highlight a couple of those reasons throughout this presentation, such as time from administration to reported and the issue of inventory being resupplied on a regular basis. So there's always inventory in the provider's office. However, there is clearly a need to improve efficiency of vaccination at administration sites. We need to ensure that administration sites can handle the supply they have and better match demand to where supply is. So a couple of things that we're working on with jurisdictions and with administration sites is to improve throughput at the site through workflow and additional staffing. Improve scheduling. I'm sure all of you have had the experience of either you or a loved one or a friend having trouble scheduling vaccine visits. So both schedule management and aligning with the better throughput at the sites and knowing when these sites will have doses in their clinic is really important. We want to better match supply to throughput capabilities, and we want to improve vaccine supply-demand mismatch. So one of the really important things we need to do in the coming days is make sure that we are able to direct people to where vaccine is by using things like state-level vaccine finder tools and moving vaccine to where it's needed. And this is an incredibly complex process. It sounds super it sounds like a super straightforward thing to do and incredibly rational, but it takes a very large amount of work. We do have several best practices from states that are doing this well, and using those best practices to demonstrate how other administration sites can shift their practices and improve throughput is a really important goal in the next several days. So in conclusion, we've had an unprecedented rollout of a new vaccination program, which has reached nearly 20 million people. By the end of today, we will have vaccinated over 20 million people over a very short period of time, also during a surge in the epidemic. However, supply continues to be a rate-limiting factor, and we can do all we need to do with increasing efficiency and getting those doses that aren't getting into arms more rapidly, but we are still facing limited supply for the near future. As vaccination expands and vaccine uptake continues to increase, we need to focus on rapidly administering doses and reducing bottlenecks in the system. And these bottlenecks can really be anywhere from manufacturing to shipping to distribution to administration. No person should be left behind. We have to continue to focus on equitable access, even as we have our eyes on vaccinating as many people as rapidly as possible. This means we need to reduce barriers to vaccination and increase engagement to build trust in communities. Particular communities that we are concerned about in terms of both access and demand are essential worker populations. As states are expanding age groups to open up vaccination, it is much easier to communicate and to get older adults vaccinated than it is essential workers. So vaccinating our essential workers is going to be an incredible amount of work. Also ensuring homebound adults and older adults who may not have the ability to use technology to schedule vaccine appointments will be really important. That includes adults who with reduced literacy and English not being a primary language. We also need to increase access to persons with disabilities. Persons with disabilities are, many will not be able to come to some of the vaccination clinics that are currently available, and we need to find ways to either vaccinate in people's homes or set up designated spaces that can vaccinate persons with disabilities. We continue to focus on our efforts on increasing demand, but also bringing vaccination to racial and ethnic minority communities. It continues to be we need both. We need access, and we need vaccines to be near people, and we also need to build trust and continue to listen to and engage with these communities. In closing, vaccinating the country will take all of society to work together and requires continued persistence, engagement, and community. We ask that all of you who are listening today think of some way, whether or not you are eligible to get vaccinated or you are still waiting, to take action and do something to support the vaccination program, whether it is checking in on neighbors who may be eligible for vaccine and driving them to their appointment, or setting up or working with your community to set up a vaccination clinic in a school or church. This takes more than a village. This takes an entire country, and it will be a lot of work. But vaccination, as all of you know, remains one of the best ways for us to end this pandemic and get life back to normal. Thank you.
Thank you, Dr. Cohan. Dr. Dushan, your hand was up first.
Thank you, Dr. Cohan, and everyone for the update and the tremendous work that you're doing to support us. This is Jeff Duchenne of Public Health, Seattle, King County, Washington. And I can't tell you how gratifying it was to hear President Biden yesterday acknowledging that the unpredictable supply of vaccine and the inability to forecast from week to week is a major barrier for getting vaccines into the communities and the eligible populations here at the local level throughout the country. I'm wondering if you can say a little bit more about the vaccine supply, what we can expect and how we will be able to overcome this inability to forecast. I heard the president say that there are going to be more reliable information and predictable data provided. Can you tell us more about how that's going to work?
Thanks, Dr. Dushan. Yes, this is the most. This is one of the more challenging barriers. Is not knowing the prediction and being able to predict and forecast out supplies so that people know when they'll be getting doses and can schedule more than just a couple of weeks out, especially. So the question about resolving this issue is being worked on as we speak. I believe there was some additional a discussion about that on a White House briefing today. We are trying to understand the data better and work with companies to have a better sense of our forecasting and actually to increase supply to jurisdictions when we can. But we do want to be careful not to increase supply so much so that it puts us at risk and we don't have some of our regular we're too close to the edge of our supply management. So I don't have specifics on ways that that's being managed. I am hoping we hear more details in the coming days, but that will be a collaborative process with HHS, CDC, and the White House Task Force to resolve this.
Thank you. I really appreciate and look forward to that. Will CDC be providing any guidance to states about how to manage the second dose issues? Initially those doses were being reserved, so we didn't have the need to do anything special to ensure that everyone that got a first dose would be guaranteed a second. At this point, though, that is no longer being done. So I'm wondering if there will be any sort of strategies that you would recommend to us to ensure that we get second doses in on time.
Yeah, so just to clarify, we are still allocating second doses when we are allocating the initial doses. So we do make those doses available 3 or 4 weeks out, depending on the product. And we are managing that to ensure that there is a second dose for everyone who gets a first dose. It's not being held back in that we're not holding back inventory, but we are prioritizing and directing inventory through our supply management system to ensure that there are second doses available.
Thank you for that clarification.
So, Dr. Cohan, let me take this opportunity to say, first of all, thank the CDC for being very flexible in allowing states to use a vaccine that was dedicated to long-term care facilities where that dosing was overcalculated. So in my state, the formula used to calculate the amount of dose given for the long-term care facilities provided extra doses that were sitting there, and we were able to reach out to you all and have that moved out of that particular pot and used in the community. So thank you very much. But the other comment I wanted to make is that there still is there's a deficit in our ability to reach out to communities that are linguistically challenged or have cultural differences that need to be addressed. And I want to stress that that's very important as we begin to move out of these first tier, first phase groups and into the phase 1B and C, and in particular 2. So we really need to continue to focus on that and provide guidance and provide materials for the states in order to move forward on that. Dr. Bata.
Thank you.
Bata, sorry.
That's okay. Thank you, Dr. Cohan, for giving us that review and providing a little context regarding the differences between doses allocated and distributed and administered. That's been a huge point of confusion for a lot of people. I've mentioned this as we've talked about equity in allocating doses in the past. And I just want to bring this up again, similar to what Dr. Romero was saying, that I'm very, very concerned that we are pushing speed over equity. And having worked specifically with our African American and Latinx communities and our liaisons from the health department, there's a lot of hesitancy, and a lot of that is due to the historical trauma, past injustices, both by public health and the healthcare system, and current injustices that are occurring. And there needs to be a lot more conversation, both at a local level, but also a national level, so that we can give the people the information they need to make the best decision for vaccination. But I really, I see it in our own state that they are being passed up, that our elderly, our 65 and older are starting to get the vaccine, but they make up, they consist of 97% white individuals. And so we're not getting this vaccine into the communities that have been the most severely impacted by COVID. And so I think we really, I see the commitment in the slides, but we need to keep acting as well. Thank you.
Thanks, Ms. Bata, for that very clear understanding of the challenges. This is, the CDC approach and the government approach is to not leave anyone behind, continue to focus on equity while we expand vaccination into new populations. And we are keeping our eye on that very closely, and we'll be looking at our data as it comes in on race and ethnicity to make sure that we are doing that. And we're also looking at our data to help jurisdictions identify which parts geographically of their state may be getting underserved, either because of access or because of hesitancies. So looking at sort of distribution compared to uptake in socially vulnerable communities and in rural communities and other places. It's specific in response to your comment about racial and ethnic minority communities and the large amount of vaccine hesitancy in those communities. One of the key things that we think is critical is to engage our national and local Black partners, organizational partners, to such as BlackDoctors.org and NMA and Black Nurses Association. There's many, and organizations that support Latina communities, and give them what they need to talk to their communities and to engage their communities and vaccinate their communities. And so it's important both that jurisdictions work with these organizations who really understand the challenges that the community faces. But additionally, we need to do this at a national level, and we are going to be laser focused on that in the coming weeks, as you'll soon hear more about. But I don't know if I can't remember who's here from NMA, but if anyone from NMA would like to add any comments about how your organization is thinking about addressing vaccine hesitancy in Black communities. We can also come back if you want to say anything at a different time.
Hello, can you hear me?
Yes, we can.
Okay. This is Dr. Sonja Hutchins. I'm a professor in the Department of Community Health and Preventive Medicine and More Health.
Actually, if you could speak a little louder or closer to the microphone, please. Sorry.
It's here. Can you hear me now?
Yes, great.
Better? Okay. I was just saying and introducing myself. My name is Dr. Sonja Hutchins, and I am a professor in the Department of Community Health and Preventive Medicine at Morehouse School of Medicine, and a retired captain in the United States Public Health Service, where I spent my entire 30-year career at CDC working on vaccines and the prevention of vaccine preventable diseases, and also pandemic and emergency public health preparedness and response, and particularly as it related to vulnerable populations. And I'm representing the National Medical Association today as a member of the NMA, and also someone that has a lot of experience in working with the most vulnerable populations in our society. So with that, we have been working on hesitancy from the very beginning of the pandemic as a organization as the oldest and largest organization of African American physicians. We've had webinars as early as the end of March, and throughout the year, a COVID-19 task force has been set up. And we have been meeting with the manufacturers as well as CDC and other organizations to combat the hesitancy problem. It was gratifying to hear the robust vaccine safety monitoring, because that really helps our communities understand better the safety of the vaccines. And that goes a long way in promoting confidence in the vaccinations. So we're also concerned about the administration of the vaccine in our communities. And we know that there's supply issues, and how can we overcome those issues so that the vaccine is equitably administered in the underserved populations throughout our country. We spoke with CDC last week about that. We shared some ideas. We're continuing to work on that, because distribution and administration of vaccines in the communities where people are accepting the vaccine. So we are very hopeful that we'll continue to work together with CDC and other partners to reach the most vulnerable sectors and communities in our nation. Any specific questions you had for the National Medical Association?
No, thank you. That's very helpful.
Thank you, Dr. Goldman.
Thank you. So this was very helpful. Many of my colleagues I know want to be able to provide the vaccine and have access for the communities, and are being denied the ability to do that. Plus, we know that on a state-by-state level, each governor can choose to follow the guidelines or not. And we know many governors are completely ignoring the CDC's ethical framework. And we know that healthcare workers on the front lines, essential workers, are being denied the ability to get a vaccine in favor of different guidelines being enacted. So with that, and the unethical occurrences of those with a lot of money donating to facilities and getting vaccinated above and beyond those who should get it first based on our ethical framework, do you foresee any stronger federal involvement or a more national strategy to take over in some of the states that are not quite following an ethical framework, so that we can ensure equity and actual vaccine distribution in a more fair manner for some of the states who are not following the framework?
So I'll address the first part of what you said, which is that incorporating primary care physicians into our as to be vaccinators and administrators of COVID-19 vaccine is something we would really like to do in the near future as supply increases enough. And I do think that there are ways that we can do it in a limited way, so that providers who serve large portions of the population or can act as vaccinators for other practices. There's a lot of challenges right now with the limited number of doses and the high number of the high minimal requirement to order. But I completely agree with you. There are groups of people that will that we need primary care doctors to vaccinate, and many people still will want to wait to get vaccinated at their primary care doctors or at some place that individual recognizes as a provider. We are absolutely thinking about federal ways that we can support jurisdictions and getting vaccine distributed and administered equitably and efficiently. I don't know exactly what you're referring to. There are lots of reports about in certain administration sites and in locations about individuals who are not eligible for vaccination getting vaccinated. It's challenging we don't want to be so rigid that doses are wasted, but we do believe it should be for any vaccination provider, fairness and fairness should be a critical factor. And, our preference would be for pharmacies and other organizations that are vaccinating to have wait lists of people who are eligible for vaccine. And I think that most organizations are doing this. We're just seeing the stories of some places. But from a federal perspective, we are here to support the jurisdictions, and we anticipate continuing to provide them guidance as needed. But primarily around improving their programs.
If I could just quickly follow up to clarify, for example, firefighters being eligible, but policemen and teachers not being allowed to get vaccines, issues like that on a jurisdictional level.
Yeah, no, I think, ACIP has made their recommendations and the framework is there for people to use. But jurisdictions do have flexibility in how they implement those recommendations.
Thank you. Dr. Lee.
Thank you so much. I just wanted to perhaps put in a plug for ensuring that we keep two metrics visible. The one we are all aware of and should be aware of is the one on efficiency. And absolutely agree, we do not want need doses in freezers or any wasted doses. But I think we also have to bring into view measures of equity. And I think holding us to both standards is really important so that we can ensure that we are accountable for how we're delivering vaccine. In addition, I think what it offers us is by having sort of a standard way to measure and recognizing all the challenges with measuring equity, but just having a measure around equity would allow us to also just redouble our efforts in communities where we know there are high rates of disease and high rates of vaccine hesitancy. And it will allow us to focus those efforts in a more specific manner as opposed to a general approach, which we need as well. So, I guess I wanted to maybe ask if there are considerations. You had mentioned specifically race, ethnicity as one dimension. And in the past, we've talked about zip code or even at the county level, thinking about the social vulnerability index or the COVID-19 pandemic index as a proxy for understanding risk in communities and how well we're doing in vaccinating in those communities. I think that could give us another target to focus on and ensure that as we're efficiently delivering vaccines, we are also equitably delivering vaccines. The other is that in healthcare delivery systems, we are also, looking at primary or preferred language to ensure our rates of vaccination are similar among English and non-English speakers. But having examples of these measures of equity, even if they are not ideal or the thing we want to measure, I think anything that we can bring into our vision will help us ensure that we're doing a good job at it.
Thanks, Dr. Lee. And the measures that you're speaking about related to SVI and zip code and vulnerable populations, we are actively working on, and we do anticipate being able to report in those ways in the near future. I do just want to put a plug in. 50% of our reported data on race and ethnicity is as across all of our race and ethnicity, across the response, we often have around 50% unreported. And so provider reporting of race and ethnicity is really critical. But we are also intend to use SVI as and other measures as proxies.
Thank you. Dr. Hayes.
Yes, Carol Hayes with the American College of Nurse Midwives. I want to say thank you, first of all, to HHS and CDC for the funding that has come along, not just with the vaccines themselves, but with the other types of monies that have been given. In the state where I reside, the vast majority of how we have been able to roll out the COVID vaccine was from federal funding. So I just want to say thank you. I also want to say that I think that we need to look at the IIS systems in different states. For instance, where I live, we are the worst state in vaccinating individuals in the United States because our IIS system is from 1996 and it has not been updated since. And so we are so slow at reporting our doses given that Operation Warp Speed would not give us more doses. So we're in this horrible catch-22. I also want to say that the state where I live has punted the vast majority of how to roll out the vaccine to the counties. And some of our counties are so poor and so underfunded that they have had a difficult time developing their own registration systems and their own drive-through systems. And so this feudalism of, my state has 159 counties. So we have a horrible situation where no one is really coordinating it on a really global way. So I was really happy to hear that you're going to recommend that the states that have had an efficient system, that their best practices can be shared with other states. So I just want to thank you very much.
Thank you. Dr. Long.
Yes, thank you. We all have different experiences, and we have all been very concerned about being sure that we don't want disparities in deaths and disease to get worse in spite of our best attempts. I think that they will, because those of us who have colleagues, family members, friends who are not paid by a healthcare institution know how much self-advocacy it takes to get an immunization. Even when you're on the right list, you're in the right ballpark, it is very, 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 very difficult. It took hours for me to get an immunization for my husband, who's now retired, because things would happen like they asked so many things. By the time you filled out the things on the computer, there were no more slots for that time. Then you go to another one and the same thing would happen. This is happening in lots of ways. But I have two thoughts. One is that I think Mr. Biden's administration could be very useful. And that is, I really don't think it will help to educate people who don't trust the system about how safe the vaccines are if it's us telling them. I really think we need a grassroots organization and people knocking on doors and people that are their neighbors. And I just wonder if, a Biden, Obama kind of approach might be the way to do this, because I think we are going to have very disparate numbers in who's able to get immunized. And the other thing that I think there's been a complete failure, at least in Philadelphia, is that the big university institutions who have taken care of, millions of patients have no plan, still have no plan. If we ask, they say, they don't know. These are big places like Penn and Jefferson and Temple. They don't have any plans for immunizing their patients. So this is going to be patients getting this either through their doctor's offices, which I don't know when that's going to happen, or through their counties. And the counties are very different. I also think we ought to get people who have some time, like retired physicians, nurses, et cetera, to be able to give immunizations on weekends. Why should we not give immunizations on weekends when people are dying on weekends? I can't tell you the relief I felt when I had gotten my first dose and my husband had gotten my first dose, I said, if we're not infected in the next 10 days, we will not die from coronavirus. And you know, there are a lot of people who still will. So you can see I'm upset, passionate about this is still the haves are getting more vaccine than the have-nots.
Thank you for those comments. I'm afraid we're starting to run short of time, so I hate to cut off this discussion at this point. But Dr. Cohan said, please email any comments that you had or questions, and she will address them through email. So we're going to move on to our next speaker, which is Dr. Catherine Fleming Dutra, and she will talk about the COVID-19 vaccine effectiveness studies. Dr. Fleming.
Thank you. Next slide. So to begin, why do we need post-authorization vaccine effectiveness, or VE, estimates? So first, real-world performance of vaccines can vary from that seen in controlled trial settings, and we can only learn about that through observational vaccine effectiveness studies. Both authorized COVID-19 vaccines have recommended 2-dose schedules with dosing intervals of 3 and 4 weeks. And we know that outside of clinical trials, in actual practice, the timing and coverage of second doses can vary from what's recommended. And both authorized vaccines have specific cold chain requirements that may be difficult to implement in practice. Additionally, post-authorization VE estimates will also build on evidence from the phase 3 clinical trials, including VE in key subpopulations and outcomes for which the trials may have had limited power, follow-up time, or were not designed to address. And examples of these outcomes include severe disease, SARS-CoV-2 infection and transmission, and duration of protection. Next. While we would like to have observational data on all outcomes in all populations, we recognize the need to prioritize and focus on information that will be most useful for guiding policy. Our team's priorities have been developed based on the results of internal and external input. Our most immediate priority in the first 2 to 4 months of vaccination, meaning right now, is to answer the question, does vaccine protect against symptomatic disease as expected? After that, the subsequent priorities include estimating VE against key outcomes of severe disease, non-severe disease, and SARS-CoV-2 infection and transmission, estimating VE in key subpopulations, including adults 65 years of age and older, including those living in long-term care facilities, people with key underlying health conditions, such as those who are immunocompromised or have obesity or diabetes, and racial and ethnic populations that have been disproportionately affected by COVID-19, and estimating VE for regimen-related questions, such as single dose, prolonged dosing intervals, and mixed dose schedules. In the later stage, additional key policy questions include those around viral evolution and whether genome changes threaten vaccine effectiveness, duration of protection, and estimating comparative VE. Is one product better than another? Next slide. And while there is undoubtedly a need for post-authorization vaccine effectiveness studies, there are some challenges inherent to observational COVID-19 VE studies that can bias VE estimates. One of the biggest challenges is that the decision to be vaccinated may correlate with the risk of disease, and people who choose to get vaccinated may also adopt other prevention behaviors that would decrease their risk of disease, or they may engage in more risky behavior because they feel protected. Prior infection may bias the VE estimates, as it confers protection against disease, and known prior infection may be associated with the likelihood of vaccination. In addition, COVID-19 epidemiology is highly dynamic, which makes it tricky to plan when and where to do VE studies. And multiple products are in use simultaneously, further complicating VE studies. Given these inherent limitations, we have developed a portfolio using a diversity of methods to address our policy priorities. Next slide. This table provides a summary of currently planned COVID-19 VE assessments. For each of the policy priorities listed in the left column, we sought to plan both studies with prospective data collection, which are listed in the middle column, and studies that leverage big data, such as electronic health records or claims data sets, listed in the right column. Prospective studies allow for richer data through interviews or surveys of participants and chart review, while larger data sets offer greater statistical power and efficiently make use of existing data resources. We're going to hold just for a second to try to fix some technical issues. All right, so we'll try again with a new microphone. All right. So for this work, we have aimed to facilitate rapid launches of these assessments by leveraging existing platforms and to harmonize and coordinate.
You are joining the call now.
Across platforms in the US government. All right, next slide, please. All right. Now, let's talk about specific assessments, and we'll start with the most immediate question of whether vaccine works as expected to prevent symptomatic disease. And to do so, we are conducting a prospective assessment among healthcare personnel. Next slide. For this, we are utilizing a prospective test-negative design among healthcare personnel. A test-negative design is a type of case control study which enrolls people with a certain clinical syndrome, in this case, healthcare personnel with a COVID-like illness who are tested for the disease of interest, in this case, COVID-19. And cases are those who test positive, and controls are those who test negative. The primary objective of this assessment is to evaluate the vaccine effectiveness of a complete schedule of COVID-19 vaccine against laboratory-confirmed symptomatic COVID-19. And if feasible, we'll do this by vaccine product. The secondary objectives are several and will include assessing vaccine effectiveness by the number of doses received, if this is feasible based on the number of participants who have received 1 or 2 doses. The assessment launched this month in January and will enroll until sites have reached a vaccine coverage of greater than 80% with 2 doses. Interim analysis may occur as early as March, but the timing depends on vaccine coverage at the sites and the rate of case accrual. Next slide. So this VE assessment is being conducted across 26 states in 34 sites that have over 500,000 healthcare personnel. Next. Now let's turn toward the next priority, assessing vaccine effectiveness among older adults, including residents of long-term care facilities. Next slide. Among adults 65 years of age and older, several assessments are planned, including a CDC-led case control assessment of VE linking hospitalized COVID-19 cases from CDC's COVIDNet surveillance system with claims data from the Center for Medicare and Medicaid Services, or CMS, and an FDA-led cohort analysis of CMS claims data. Both of these assessments will conduct separate analyses among adults 65 years of age and older who reside in the community and those who reside in long-term care facilities. For these analyses, the results are not expected until at least this summer to allow time for vaccination to occur in this age group, cases to accrue, and the data to be available. Next slide. Among residents of long-term care facilities, we plan to use data from the National Healthcare Safety Network, or NHSN, long-term care facility surveillance and vaccine coverage modules. These data will have weekly aggregate counts at the facility level of new laboratory-confirmed COVID-19 cases and vaccination status among all residents and among new COVID-19 cases. Using these data, we will plan to calculate weekly attack rates among vaccinated and unvaccinated to estimate VE among residents of long-term care facilities. The first transmissions with these data will be available starting in early February, and to perform the initial analysis will require at least 8 weekly transmissions from facilities with at least 50% vaccine coverage. And there are plans to conduct ongoing analyses as reporting into these NHSN modules will be ongoing. Next slide. Additionally, we are planning assessments of vaccine impact in long-term care facilities that have the potential to be more rapid, including ecologic analyses of vaccine coverage and COVID-19 disease rates among residents of long-term care facilities, and assessments of vaccine impact may also come from outbreaks with descriptive analyses before and after vaccine use. Next slide. Another key priority is to assess the vaccine effectiveness against infection, including asymptomatic infection, and importantly against transmission, which can only be evaluated prospectively. Next. In order to do this, we are leveraging an ongoing cohort of more than 5,000 healthcare personnel and first responders, with weekly testing for SARS-CoV-2 infection and assessment of secondary transmission among household members. The cohort began in July 2020 and will continue through March 2022. We are currently working to expand case-ascertained household transmission studies to include the general population during widespread adult vaccination. Next slide. Now let's move to the outcomes of severe disease, hospitalization, and non-severe disease, and the key subpopulations of those with underlying health conditions such as immunocompromising conditions, and racial and ethnic groups who are disproportionately affected by COVID-19. Next. For these outcomes and groups, we will use a test-negative design and conventional case control design with hospitalized controls. These VE evaluations will be designed to assess severe disease and hospitalization and non-severe disease, and they will utilize sites selected to include populations with underlying health conditions, racial and ethnic groups who have been disproportionately affected by COVID-19, and American Indian and Alaska Native populations. We'll also be conducting screening method analyses, which are assessments that look at vaccination coverage among a group of cases, for example, cases detected through ongoing COVID-19 surveillance, and compare that with vaccination coverage among the overall population from which the cases arose. So, for example, people from the same state. And we'll be conducting big data analyses, including electronic health records and claims-based assessments. Next, please. We're also planning assessments to measure the vaccine impact in the population. Next. And for this, as I've already alluded to, we are planning ecologic analyses of the association of disease incidence and or seroprevalence with vaccine coverage, as well as comparisons of expected vaccine impact for mathematical models with actual observed impact. Next. As we've discussed, important questions include assessing vaccine effectiveness for regimen-related questions, including use of a single dose or prolonged dosing intervals, meaning more than 3 to 4 weeks between doses, or even mixed dose schedules, meaning use of more than one product in a 2-dose series. Our ability to answer these questions using observational studies will depend on whether we capture enough of these events, which may occur in practice even though they may not be recommended. All of the platforms we've discussed, with the exception of the National Healthcare Safety Network, or NHSN, will collect individual-level information on dose dates and vaccine type, and thus they have the potential to answer these questions. However, for the early phase vaccination among healthcare personnel and residents of long-term care facilities, we anticipate good adherence to dosing recommendations, including the use of 2 doses of the same product and to the dosing interval. So it's unlikely that we'll have enough variation in the data from healthcare personnel and residents of long-term care facilities to answer these questions. Thus, our best opportunity to answer these questions may come from large prospective electronic health record and claims-based assessments among the general adult population. Next slide. So how can we assess whether viral genome changes threaten vaccine effectiveness? The prospective platforms for general adult population will collect specimens from cases, where possible, for whole genome sequencing. It's important to note that this will not be performed in real time, and these evaluations may not be powered for variant-specific VE assessments. Nonetheless, it is our hope that these specimens can be leveraged to help answer this question. Additionally, a separate team in the Vaccine Evaluation Unit is dedicated to assessment of vaccine breakthrough cases, including investigating whether SARS-CoV-2 variants lead to breakthrough cases and have the potential to impact VE. I want to emphasize that this work is part of the broader CDC efforts to monitor the impact of SARS-CoV-2 variants, and this will be addressed more fully in a later presentation today. Next slide. So what are our plans for assessing VE among children and pregnant women? For children, we are planning a prospective test-negative design assessment to evaluate VE against COVID-19 hospitalizations, and this work will leverage an existing surveillance network of approximately 20 to 40 sites for pediatric COVID-19 hospitalizations, including intensive care unit, step-down, and general inpatient admissions, and multi-system inflammatory syndrome in children, or MISC. Additionally, electronic health records and claims database analyses will be used to estimate VE in children. And for pregnant women, we're exploring electronic health record, cohort, and prospective case control VE assessments. Next slide. So in conclusion, there's an urgent need for vaccine effectiveness data to guide policy. The VE portfolio leverages multiple platforms, data sources, and methods. Early VE assessments will focus on healthcare personnel and residents of long-term care facilities. And the portfolio will continue to evolve as more information from phase 3 trials and real-world evidence become available. So with that, thank you, and I'm happy to take any questions.
Thank you very much for that very informative talk. This is open at this time for discussion. Dr. Dushan, I see your hand is up. Nope, I guess not. Any questions? I'm not seeing any questions or comments. Thank you very much for that presentation. We'll move on to the next presentation by Dr. Oliver, who will present workgroup interpretation and next steps.
Thanks and good afternoon. Next slide. So first, to summarize the clinical trial data that was presented earlier from AstraZeneca. Next slide. The workgroup reviewed immunogenicity data where neutralizing and binding antibodies were measured in participants after 1 dose and a 2-dose series. The responses were similar to convalescent sera comparison. A Th1 biased T-cell response was documented, and a 5 × 10⁻⁻⁻ dose delivered as a 2-dose series 28 days apart was selected for the U.S. phase 3 clinical trials. Next slide. The workgroup also reviewed safety data from the AstraZeneca vaccine. From the phase 1-2 studies, local and systemic symptoms were mild to moderate in severity. Injection site pain, feeling feverish, muscle aches, and headaches were the most common symptoms reported. Reactogenicity symptoms were lower after the second dose, although there were small numbers of individuals who received a second dose in those trials, and lower in older adults. No vaccine-related serious adverse events were reported. The interim results from the global phase 3 trial show similar results to the early phase clinical trials. Reactogenicity symptoms were milder and reported less frequently after the second dose and in adults 65 years of age and older. They also reported results from the clinical hold, where the study was paused due to the report of transverse myelitis in the UK. The FDA reviewed neurological events in all trials, and after this independent review, the study was allowed to be resumed with changes, including an independent expert neurology panel. Next slide. So in addition, AstraZeneca presented preliminary data from the interim global efficacy analysis. Over 11,000 participants in the UK and Brazil were included in this interim analysis. There were several dose regimens and interdose intervals included in this analysis. The VE estimate for the standard dose regimen, which is what is currently being studied in the US phase 3 trials, was 62%. A pooled VE estimate, including individuals with a lower dose as the first dose, as well as a more delayed dose schedule, was 70%. Next slide. They also discussed their plans for the US phase 3 trials, which will be the primary basis for the EUA application. To date, they reported over 32,000 people enrolled in the phase 3 trials. The primary endpoint is symptomatic, virologically confirmed COVID disease. And the presentation earlier today discussed trial enrollments in diverse populations, including diversity in race and ethnicity, age, and underlying medical conditions. Next slide. Overall, the workgroup felt that the early phase 1-2 data shows induction of binding and neutralizing antibodies, as well as T-cell responses, with a favorable safety and reactogenicity profile, supporting the advance to phase 3 trials. Safety pauses are expected with large clinical trials and indicate that the process is working appropriately. However, transparency around the safety pause and resolution is critical. And overall, we await the results of the US phase 3 trial for an EUA application with 2 doses of the standard dose of vaccine, 28 days apart. Next slide. So next to the workgroup interpretation, COVID-19 in children. Next slide. While the overall burden of COVID may be lower among children, preventable infections, hospitalizations, and long-term sequelae and deaths are an important public health problem. Clinical trials to evaluate safety and immunogenicity of COVID vaccines in children are essential. And given disparities noted among COVID cases in children and MIS-C, it will be crucial for pediatric clinical trials to enroll a diverse population. And we look forward to reviewing data from these clinical trials as they become available. Next slide. So next for the VE studies. Next slide. Real-world vaccine effectiveness studies are needed for a variety of populations, ages, and underlying medical conditions. Diverse trial designs will also be important to address a variety of questions. The work group discussed many of these that can hopefully be addressed through these studies, including VE after a single dose or a mixed series, VE in immunocompromised individuals, and duration of protection. In addition, isolates obtained through the VE platforms can help address concerns around SARS-CoV-2 variants. Next slide. So for more on the new variants, next slide. In the fall of 2020, several SARS-CoV-2 variants emerged with changes in the receptor binding domain of the spike protein. Preliminary studies indicate that these changes can confer increased transmissibility. This table outlines 3 of the concerning variants: the B117 variant from the UK, B1351 from South Africa, or P1 from Brazil. The number and details of the amino acid changes are listed here as well. Next slide. So while we expect changes in the virus over time, these have been of particular concern for this specific issue. Do these variants have the ability to evade vaccine-induced immunity? Next slide. Several preprint studies have been made available over the past several weeks. Following vaccination, limited numbers of study participant sera were tested in neutralization assays. Regarding the Pfizer vaccine, studies have demonstrated equivalent neutralization titers against a panel of different variants. Reductions to neutralization titers have been noted against the UK variant with 1.2 or 3.9-fold reduction. And one study found a modest reduction for some neutralization against certain spike mutations from the South African and Brazil variants. However, these were tested against individual mutations. Regarding the Moderna vaccine, the same study again found modest reduction for neutralization for mutations in the South African and Brazil variants. Another study found no significant impact on neutralization titers against the UK variant, but a 6-fold reduction for the South African variant. And the links to each of the preprints are here. Next slide. Surveillance is critical as we monitor these and possibly other future variants in the US. These surveillance efforts are detailed on the CDC website at the link on the slide, but we wanted to highlight them here as well. The national SARS-CoV-2 strain surveillance is being scaled to sample hundreds of samples per week and will allow for broad characterization of the viruses. Surveillance is also underway in partnership with national reference labs and universities, occurring within state and local health departments, and through a national consortium of around 160 labs called the SPHERES Consortium. In addition, additional investigations will be conducted as vaccine breakthrough cases are identified. Next slide. So overall, in most of the studies reviewed, there was minimal to moderate reduction in neutralization activity for vaccine immune sera in some persons. The implication for real-world effectiveness are unclear. Sera from mRNA vaccine recipients had higher neutralization activity than COVID convalescent human sera in the early phase clinical trials. In addition, a minimal reduction in neutralization activity may not be clinically relevant. Most of the studies mentioned previously were conducted using pseudoviruses, which are more sensitive to neutralization. And importantly, these are limited studies with small numbers. The evidence is quickly evolving, so there will need to be a continued review of the data. Studies evaluating full sets of mutation from the variants are likely more informative than studies of single mutations. And studies of vaccine breakthrough cases are planned, and these may serve as an early warning. And finally, Moderna announced this week that they are in the process of developing a vaccine against the South African variant. Next slide. So next, I wanted to briefly discuss some recent updates to the clinical guidance around COVID vaccine dosing and schedules. Next slide. The mRNA vaccines are recommended for a 2-dose series administered intramuscularly. The Pfizer vaccine doses are recommended to be given 3 weeks apart, and the Moderna vaccine is recommended to be given 4 weeks apart. Persons should not be scheduled to receive the second dose earlier than the recommended intervals. And overall, the second dose should be administered as close to the recommended interval as possible. However, if it isn't feasible to adhere to the recommended interval, the second dose of the Pfizer or Moderna vaccines may be scheduled for administration up to 6 weeks or 42 days after the first dose. Next slide. Next, to address discussions of alternative dosing or schedules, currently the recommended schedules and doses are from the phase 3 trials where safety and high efficacy were demonstrated. If data become available for alternate schedules or doses, ACIP can review data and consider new recommendations. However, in the absence of additional data to support alternative schedules or doses, the current recommendations will remain. Next slide. The mRNA vaccines are not interchangeable with each other or with other COVID vaccines. Either vaccine series may be used. ACIP does not state a product preference. And every effort should be made to determine which vaccine product was received as the first dose. In exceptional situations in which the first dose of the vaccine product cannot be determined or is no longer available, any available mRNA COVID vaccine may be administered at a minimum interval of 28 days between doses. This longer interval was chosen since it's presumed that at least one of the doses may be the Moderna product. Next slide. So while the vaccines are being used under an EUA to allow for appropriate safety surveillance, the mRNA vaccines should be administered alone with a minimum interval of 14 days before or after administration with other vaccines. This is a reflection of the lack of data regarding co-administration and the need for careful safety surveillance, not because there are any known problems with safety or efficacy with concomitant administration. Along those lines, mRNA COVID vaccines and other vaccines may be administered within a shorter period in situations where the benefits of vaccination are deemed to outweigh the potential unknown risks of vaccine co-administration, such as Tdap after a dirty wound, Tdap during pregnancy, vaccines during an outbreak, etc. If mRNA vaccines are administered within 14 days of another vaccine, the doses do not need to be repeated for either vaccine. Next slide. And finally, next steps for the work group. Next slide. Any vote on the use of additional COVID vaccines will take place at an emergency ACIP meeting once FDA has authorized the vaccine and data are reviewed by ACIP, including safety and efficacy results from the phase 3 trials. The Janssen vaccine may have results from their phase 3 trial within the next several weeks, based on public statements by the company and others. This is an adenovirus 26 or Ad26 vector vaccine, and the current US phase 3 trials are evaluating a single dose. Next slide. So I just wanted to provide a very quick overview of the ad vector vaccines, since this is where we'll be pivoting to for future COVID vaccine discussions. The Ad26 vector, again in the Janssen J&J product, is a non-replicating vector. It has been used in other vaccines. J&J has an Ad26 Ebola vaccine that has been used in broader populations, including pregnant women and children. So unlike the mRNA platform, we will have a little bit more experience with this platform in various populations. However, one of the lessons learned previously through adenoviral vector vaccines is that prior exposure to the vector could possibly reduce effectiveness. So that takes us to the next ad platform, the chimpanzee adenovirus vector. It is also non-replicating, and the chimp ad vector can circumvent pre-existing immunity to human adenovirus vectors. We look forward to providing updates from the phase 3 trials of these vaccines as they become available. Next slide. Thanks, and happy to take any questions.
Thank you very much for that presentation, Dr. Oliver. As usual, excellent. We're open for discussion. I see Dr. Alt had his hand up early. Go ahead, Dr. Alt.
Well, I have an immunology question, and I'm going to get past my knowledge of immunology pretty quickly. Do we know if any of those variants you mentioned, do we know if the changes are in the antibody binding sites where the host would recognize the spike protein? Are there changes specifically in that area where we might be worried that vaccination isn't going to protect against that? I know the neutralization assays probably measure that to some extent, but I didn't know if there's anything particularly worrisome if we knew the antibody epitopes.
Yeah, thanks. So I will say that the reason these particular variants are of concern is because there have been amino acid changes noted in the receptor binding domain of the spike protein. So that's why kind of all changes that the virus might make, these are the ones that we have been talking about more frequently over the last several weeks.
But is that binding domain the same thing that the host antibody recognizes?
That is my understanding. Actually, Dr. Thornburg, has she been able to join us?
Yes.
Okay.
Yeah, I'm here. Can you hear me? Yeah. So the answer to that is a little bit complicated because some of those mutations are in areas where neutralizing antibodies do bind in general, but to say that any one specific person, everyone makes a different set of antibodies. So any one individual who's vaccinated might have an antibody binding that site or might not. They might have neutralizing antibodies that bind other residues. And also people make a swarm of antibodies. So they'll make dozens of neutralizing antibodies. So if one of those antibodies kind of drops out from a mutation, the other antibodies can still be active. So on a population whole, an individual mutation may not truly escape, but for an individual, it could.
Thank you so much, Dr. Thornburg.
Are there any other questions or comments? Okay, I'm not seeing any. Oh, Dr. Kimberlin.
Dr. Oliver, you showed on your slide 22 when you were talking about dosing administration about how the mRNA vaccine should be administered alone, and you mentioned that it's because of lack of data, which I fully understand. As we begin to anticipate the day when we'll be able to use these vaccines in adolescents and even in younger children, many children and adolescents across the country have fallen pretty significantly behind on their immunization schedules. And if we had an opportunity to catch them up on the vaccines they've missed during the pandemic and administer the COVID vaccine that they, when their group is open for qualification to receive those vaccines, it would be highly beneficial. Is there any opportunity between now and the several months from now when we'll get to the point, hopefully, of authorization for use of the vaccines in children and adolescents, that some of those kinds of studies can be done so we can be better prepared for the more global health that we try to generate in our patients?
Thanks, Dr. Kimberlin. So 2 things to say on that. First of all, yes, absolutely. Those discussions are ongoing right now around additional studies that could be done in the pediatric and adolescent population overall, and then including kind of co-administration. The second point is the current clinical considerations are, for the use of mRNA vaccines in the adult population, which is, what we're using right now. Those are being updated regularly. And so I think when we get to the point that we have vaccines authorized for routine use in children, there will be additional thoughts for clinical considerations in that population as well.
Thank you. I just in follow up, if it could be done sooner, obviously the sooner it can be done, the sooner we can start taking opportunities where patients touch the healthcare system to get them caught up on their standard vaccines as well.
Thanks.
Thank you. Thank you for that comment. Anyone else have any comments or questions? Looks like that's it, Dr. Oliver. Thank you very much. Dr. Cohan, we're a little ahead of schedule. Would you like to give a longer break here, or how shall we move forward?
Yeah, so we have the public comment session scheduled to begin at 4:30 today. So I think people can keep their computers, keep logged in, keep watching, and the final session will happen at 4:30. Take a walk, hopefully, if it's not pouring like it is here.